Our next speaker is Dr. Mimi Jacobs. Dr. Jacobs is really a well-respected rheumatologist here at Indiana University, where she's been here for over 20 years. That was actually after her staff position at University of Michigan and at Duke as well. And she's actually going to be presenting a talk entitled Musculoskeletal Disease in Patients with AIH. So thank you, Dr. Jacobs. That would be your forward clicker. If you need a pointer there.
Okay, thanks. Good morning. I'm going to start out just talk about what a rheumatologist is. I usually teach the second year medical students rheumatology, and the first day I said to them, how many of you even know what a rheumatologist is? And there's only maybe about 10 kids will raise their hand. So rheumatologists see a lot of different diseases. A lot of people think we see any disease that affects what we'll call your connective tissue system. So any disease that might affect your joints or your ligaments or your muscles can be considered a rheumatic disease. So for instance, I might see osteoarthritis or carpal tunnel syndrome. Rheumatologists also see most of the autoimmune disease. So most of the classic autoimmune diseases, for instance, systemic lupus or rheumatoid arthritis or something like that. Almost all of those are seen by a rheumatologist and managed by a rheumatologist, with the exception of maybe thyroid disease and liver. We see most of them. And one reason we do see all those diseases is because most of them will affect the connective tissue system. So most of those diseases at some point during the illness will have a joint manifestation or musculoskeletal, but they may not. We may find someone with an autoimmune disease that never involves the connective tissue disease at all. The other thing I want to clarify is that a lot of times we change around terms. So if I talk about the connective tissue disease, to someone else that might mean autoimmune disease or rheumatic disease. We kind of throw around those terms a little bit, overlapping. So most of the autoimmune diseases that I see as a rheumatologist involve multiple organs. So rheumatology we think of as maybe the one specialty where the history is really important in order to make a diagnosis. Many of the diseases I treat, when I see someone and I make a diagnosis, they may be perfectly well without a single manifestation of that problem. And it may be based on the fact that 4 years ago they had seizures, and 3 years ago they had a low platelet count that was unexplained, and 2 years ago they had a rash in the sun. But when they come to see me and I maybe give them a diagnosis of what could be a pretty serious autoimmune disease, they may be perfectly fine. And so rheumatologists are all about checking out all the different organs that are involved in your body to try and sort out what someone has. Many of the organs, the patient's going to know they had problems. So they're going to know they had pleurisy or chest pain when they took a deep breath, or they're going to know their joints were swollen and painful and red. The organs we think about that someone may not be aware of include, number one, the liver. So they maybe would have profound liver elevation in the blood work, but they just know they felt punk or weren't feeling well. Or likewise, the kidney disease. Someone can present with really profound kidney disease and have no idea. So the only way we're going to find out that's going on is maybe on physical. They'd have marked hypertension, or I'd have to get their blood work. Same thing with the blood count. But most of the time, they were worked up for rheumatic disease because they presented to a doctor with a manifestation that they were looking into. But in order to make it one of our diagnoses, it's all about the history, the physical, and the lab data, and we put it all together. For a lot of my patients, I don't even need the lab data. I know what's wrong with them by the time I've done a good history and physical. So if based on what they tell me and what I find on physical exam, I may need the lab to confirm it or to prognosticate for their illness or see what other organs involvement, but they've already met criteria for the illness. Kind of different than how liver disease might present, that without the blood work, you'd never even start down that path of making the diagnosis. Other times I do need the lab data because there's all sorts of overlap in the illnesses we treat. Someone might present to me, a young woman with inflammatory joint disease, and there may be 12 diagnoses I'm considering before I've done blood work or antibodies on her and x-rays. There's a bunch of different things it can be. So it's all about looking for it before we would make a diagnosis. So in terms of what other things do we look for in a history, and obviously I'm bringing this up because there's overlap. So a lot of patients with autoimmune liver disease will also have one of the illnesses that I treat. So they asked me to kind of share with you some of the things that would be a sign of the illnesses I treat. In case any of you are wondering, I wonder if besides my autoimmune hepatitis, if I might also have another rheumatic disease. So one of the things that many of the diseases I treat share is inflammation of the joints. So a hallmark of what we would consider autoimmune disease-related joint disease versus just getting older and osteoarthritis is morning stiffness. So the diseases I treat tend to cause inflammation of the joint. So the joint not only is painful, but it might be swollen. We call that a synovitis. The lining of the joint gets swollen. And a hallmark of joint inflammation is morning stiffness. So osteoarthritis, we usually say maybe the 30-minute roll. So if you just have osteoarthritis, you might be a little stiff for up to 30 minutes in the morning. But if someone's coming into their doctor saying it takes me 3 hours in the morning before I can get mine, that's clearly a sign that this is not just osteoarthritis. And sometimes, depending on the disease I'm treating, the length of time someone might be stiff in the morning is a way I would use to gradate how serious I might think their joint involvement is. And some people might have pain, swelling, and stiffness. Others may have no joint pain at all, but a lot of swelling and stiffness. And others will have pain, but I don't detect anything on exam. So any one of those. A number of the diseases I treat also can cause what we call sicca symptoms, which is Spanish for dryness. So a lot of the diseases I treat will cause inflammation of the exocrine glands. Now, you just had to talk about the endocrine glands, and I always explain that as the endocrine glands make something that's released and it works somewhere else. So the thyroid gland will make thyroid hormone, but it goes in the bloodstream and it works all over the body, but it doesn't really do anything on the thyroid. And the exocrine glands make something that's used locally. So they'll make the tears, or they'll make the saliva, or they'll make normal mucus that all of us produce in our bronchial airways to clear pollution and stuff like that. So a lot of our diseases will cause inflammation in the exocrine glands. So it would be an important part of the history to me if someone said, my eyes are really crusty in the morning, or I can't wear contacts anymore, or I'm having a lot of dental disease despite brushing my teeth, my mouth is really dry, I can't eat a cracker without liquid. So that is also something that would make us think about it. Now, as we go through this list, you're going to notice there's a lot of overlap sometimes in the history, and we know diabetes will present that way with a dry mouth too. So just because someone is in my office and they're having a dry mouth doesn't mean that they have a rheumatic problem causing it, and that's a lot of the digging we do. So muscle weakness is definitely, so patients with my diseases can have muscle inflammation. And, but as I always teach the residents, it's very rare that if I see someone with inflammation of their muscles causing muscle weakness, that they'll come in and say to me, I'm having proximal muscle weakness. More commonly, they'll come in and say, I'm really fatigued. I look at a flight of stairs and I'm just too tired to do it, or I'm doing my hair and I just get so tired. It's a lot of times patients won't identify it as being weak. They'll identify it as just feeling punk. That gets kind of interesting because when our patients have muscle inflammation, their muscle enzymes are elevated in the blood work. But on a routine chemistry we send off, those same things that you guys are calling your liver enzymes, your SGOT and your SGPT, those are muscle enzymes. So it's actually not, but in the routine chemistries we send off on someone, there usually aren't muscle enzymes on that. So at least once a year, I'll have a hepatologist calling me and saying that a patient presented to their doctor saying, I don't know what's wrong, I just don't feel well. I'm really fatigued, having a low-grade fever, I feel punk. The doctor can't find anything on physical because a lot of times doctors won't do a muscle exam unless you complain of being weak. And they'll get the blood work and they'll say, I know what's wrong with you. You have hepatitis, your liver test. You need a hepatologist. That's what the problem is. And then inevitably the hepatologist will call me and say, I have an active myositis patient in my clinic. This person's super weak. No one checked it. So that's kind of a little interesting way that we do overlap with hepatology, because although everyone calls those liver tests, I don't think of the OT and PT as liver tests. I think of them first as muscle tests and secondary liver tests. A lot of the illnesses that I treat are, not a lot, but a number of them are associated with an increased risk of blood clots. And so patients make antibodies that affect the coagulation system, and patients are more likely to present with blood clots. A lot of times that will present with miscarriages. So a lot of the young women, rheumatic disease is much more women than men in terms of the diseases I treat. So sometimes these patients will present with recurrent miscarriages in their second trimester or something, so that the placenta will have insufficient blood flow because of blood clots, or it may a stroke, a 32-year-old with a stroke with no other risk factors, something like that. Also, along with the blood system, they may present with bruising. A low platelet count you probably think of as a sign of liver disease, and my first guess on a low platelet count would be an autoimmune disease, lupus or something like that, where patients have antibodies to their platelets. Causing that. Anemia can be a manifestation of all the illnesses I treat, sometimes because they just have what we call anemia of chronic disease, meaning they're sick and they have chronic inflammation, but other times because the antibodies will kind of rip apart the red cells. Neurological involvement, so patients can have seizures. A lot of patients with lupus will have seizures as a manifestation of it. There can be CNS confusion. So patients can have inflammation in their brain because of autoimmune disease. They may have trouble with cognition, just like people with liver disease will as well, but for a completely different reason. Many of my diseases are associated with a sensitivity to the sun. So patients will say, I never had trouble in the sun before. In the last 3 years, minimal sun exposure, and I'll have severe burns. Most of the diseases I treat can affect the heart and lungs, so they can cause pleurisy, where the lining of the lung gets inflamed and someone tries to take a deep breath and they don't want to because it hurts to have the lung expand against it, or the lining of the heart might be inflamed, so patients with that's called pericarditis may not want to lay flat because it's more painful. So, and again, a lot of this may be, you may come to see me and I may give you a diagnosis and you may not have any of those the day I meet you. So history's everything. So when I see someone and I think they have an autoimmune disease, and just to complicate it, it's very common for our patients to have more than one. And sometimes we'll teach it to the med students as if you have rheumatoid arthritis or you have lupus or Sjogren's or scleroderma. But lots of patients will meet criteria for multiple autoimmune diseases at the same time, that certain genes that you inherit from your parents will put you at risk for multiple diseases, not just one, just like that's why we have a tendency to have autoimmune hepatitis in our patients as well, because the similar genes can put you at risk. So any patient who walks in my door, I don't care what they come in with, if they come in with carpal tunnel, there's a number of things they're not going to leave my office without. And again, for instance, diabetes, a lot of diseases will present to me. So diabetes might present to me with new rotator cuff tendonitis or carpal, really common in undiagnosed diabetes. So a lot of medical problems will come to a rheumatologist first. Even depression can present to the rheumatologist because a lot of times chronic musculoskeletal pain can be a sign of depression. So a rheumatologist is not only looking for our diseases, but what other diseases just walked in my door because you're complaining of your musculoskeletal system first. So if a patient comes to see me and I'm suspecting anything, liver tests are always part of what I would do. So I would never let a patient leave my office without that, unless someone came to me with recent labs over the last 2 months or something like that. Always thyroids. We always check thyroids on anyone, since thyroid disease can present with so many of the same symptoms that our patients can present with as well. Blood count, as I said, that's one of the organs, your blood system, that patient could have a pretty profound involvement and not be aware of it. They may just be fatigued or something like that. Urinalysis, kidney, that's just the same way of looking at the kidney. So someone can come in with pretty advanced kidney disease, and the only sign of physical might be hypertension, or maybe in their urinalysis red cells, something like that. And then a lot of the other workup we do is just based on your history. I might do a chest x-ray, I might do an echocardiogram, I might do a brain MRI. So a lot of that is really, I may do a sleep study if I think you have undiagnosed obstructive sleep apnea, which many times will present with musculoskeletal problems. And as I mentioned before, this whole muscle weakness or whatever, weakness, so many different things can cause muscle weakness, and sometimes it's because the muscles are inflamed. Sometimes my patients are weak because I also use a ton of steroids on my patients. I use a lot of prednisone, or they may be weak because of thyroid disease. There's a lot of reasons. So if there's any hint of muscle disease, I'll not only do those liver tests we talk about, but I'll also do the muscle enzymes. There are 2 muscle enzymes in the lab that we send off in the blood work to see if those are elevated. So who first, the hepatologist or the rheumatologist? So if you're one of those patients who may have overlap, a lot of it really just depends on how you present, what your initial presentation is. So the literature on autoimmune hepatitis suggests that about 30% of patients will also have manifestations outside the liver. Some diseases, manifestations that would end you in my clinic, in a rheumatologist clinic. Conversely, of my patients who have what I might call a primary rheumatic problem, lupus or rheumatoid arthritis, up to about a quarter of those patients are also going to have autoimmune hepatitis. So it may be that they ended up in my clinic, and then I end up referring someone to the hepatologist. Probably a lot of those patients are missed because I use these same drugs they use. So if you present to me with active, let's say, rheumatoid arthritis or lupus or something, and you have incidental elevation of your liver test the day I meet you, and I start medications for liver and it gets better, we'll go, I wonder why the liver tests were elevated when I met them, but it's good they're not now. Next question. So I think a lot of those patients probably go under the radar screen. And in fact, I don't, honestly, as rheumatologists, we don't talk about autoimmune hepatitis that much, really. When I was asked to give this lecture, I said, sure, I'll do it. Why don't you throw me some literature on that topic so I make sure I'm up to date on it, because it's really not something we think about that much. Because of the diseases and the medications I use, some of those problems may not be apparent on blood work and go undiagnosed. We do use the hepatologist a lot. It's not uncommon. I will send someone to that. And one of the big reasons I do is just because so many of the drugs that I use can affect the liver. So another reason I never let a new patient leave without kidney and liver, whatever, is because you're usually leaving with a new prescription from me. And many of those medications that I give, I can't give you if you have kidney problems. I can't give you if you have a lot of the drugs we use for rheumatoid arthritis. I can't give you if you have any liver issues. In fact, our mainstay, our gold standard drugs, I can't give you if you have a liver problem. Sometimes I send them because someone's developed a problem, or I think it might be the drug I'm using, but I'm not sure, and I really don't want to stop using that drug. So I want some help on knowing, do you think it's the drug? Should I stop it? Do we need a liver biopsy? And other times I'll just send them because I don't know why the liver tests are elevated, and I know it's not muscle, and I need their thoughtful advice on that one. So why do patients get rheumatic disease and autoimmune hepatitis? Kind of what I was talking about before. So there's certain genes that put people at risk for autoimmune hepatitis and also for the diseases I treat. So genetically, if you have some of those genes that put you at risk, there's a chance you may have, or someone in your family may have one. So you may have autoimmune hepatitis, and your sister may have lupus, and someone else may have rheumatoid arthritis. So in terms of the autoantibodies, the other way these diseases overlap is in the autoantibodies. So the autoantibodies are used quite a bit to make diagnoses. And some of the diseases I treat, you absolutely cannot be diagnosed with that disease unless you have an autoantibody. But for most of them, it's part of making the diagnosis, but you don't absolutely have to have it. But most of our patients do, and many of them will have a number of different positive autoantibodies. And we really want to get the autoantibodies in our patients, one, to help make a diagnosis, particularly if I think you have one of our illnesses and you've got a few things in your history, but gee, a lot of people have dry mouth, whatever. So if the antibodies are positive, it can be helpful. And the other reason we do it is to prognosticate. So for instance, if I see someone with lupus and they have what we call an anti-Rho antibody, sometimes it's called an SSA, I know they would be at high risk if they got pregnant for a baby with a heart condition or something, or they're at greater risk for dry mouth. So sometimes we'll do it, or if someone has rheumatoid arthritis and they have the CCP antibody, I know they probably have a worse prognosis. They'd be more likely to progress radiographically. So we do a lot of the autoantibodies. And as do the hepatologist when they're treating you. And that's another reason kind of there's overlap, and they may want to send someone to me. If you have a first-degree relative with an autoimmune disease, there's a chance you're going to have it. So having an autoantibody does not mean you have autoimmune disease. So the classic antibody, the anti-nuclear antibody, which just means you make an antibody to the human nucleus. So the normal immune system should not let your immune cells develop antibodies to the human cell. So I always just tell patients autoimmune disease just means you're making an antibody to your cell. But a lot of patients will have an ANA with a family member and they may never develop autoimmune disease. So in and of itself, having that doesn't mean someone has it. That's something I clarify patients all the time. Doctors get an ANA a lot if someone presents with an unexplained medical problem, pleurisy of unknown reason, or something, or seizures without a clear reason. And sometimes I'll have patients said to me, and they'll say, well, my doctor said I have lupus because I have an AA. And I'll say, no, you just have an AA. Let's see if you have lupus. So if someone in your family has autoimmune disease, you're going to be more likely to have one of those. The higher the titer, the more likely. So if your hepatologist finds some of these antibodies, they may send you to us as well. People who are elderly are a little bit more likely, if they have autoimmune hepatitis, to also have one of our diseases. Rheumatoid arthritis is a classic disease of joint, inflammation, so swelling of the joints and morning stiffness. Patients, classic. Sjogren's is another disease that there's actually the most overlap between autoimmune hepatitis and the diseases I treat as Sjogren's. Calling it Sjogren's syndrome is like calling it Jacobs syndrome with Smiley. It's just the person that diagnosed it. And it was a Swedish ophthalmologist. And the Sjogren's patients are the ones who the hallmark of it is this inflammation of the exocrine glands, dry eyes and dry mouth, and vaginal dryness, and a dry cough, and dry sinuses, stuff like that. Pericarditis, just inflammation of the heart. Those patients would be more likely to have autoimmune hepatitis. Some patients get mononeuritis multiplex, which means there's inflammation of the blood vessels to the nerves, and they can present with maybe weakness in my right leg and numbness in my left wrist and a wrist strap in right hand. So different nerves can get inflamed. And same thing with systemic lupus. So the older patients with autoimmune hepatitis are more likely to have these. Some are more likely no matter what the age of the patient, and particularly Sjogren's, as we talked about, and also patients with rheumatoid arthritis sometimes have a syndrome called Felty syndrome, where they get very low white cell counts, and they may get non-healing ulcers. And those patients, that subset of patients with rheumatoid arthritis, are more likely to have autoimmune hepatitis as well. So when a rheumatologist sees a patient with autoimmune disease and liver test abnormalities, it's important that we think about autoimmune hepatitis. I'm not positive that's the first thing that honestly rheumatologists think about, but if the liver tests are up and they're still up after we see someone back, because a lot of times that's an unexpected finding. A lot of times we're just doing the liver test to make sure I can give you the drugs I want to give you, quite frankly. Then we should be thinking about sending someone to a hepatologist and saying maybe this is actually a primary disease of the liver that's going on. As I said before, that can easily be missed, because it may be that the day I meet you and I think you have active lupus with a lot of manifestations, I may put someone on 20 of prednisone that day, get their blood work, call them up and say, boy, your liver tests look funny. Let's remind me again, are you wheat? Why don't you in 2 weeks get that again? And it may be normal by then or something like that. Or maybe they say, well, yeah, I did have a six-pack the night before I met you, and we'll say, fine, let's just repeat it in a couple of weeks. Maybe it's that. So it can go under the, that really can go under the radar. So it may not get picked up. Of course, on some perspective, if it immediately gets better with low dose and it never shows up again, it may have been mild. So maybe that's good. So conversely, when a patient with autoimmune hepatitis presents and the hepatologist gets the history and physical and their manifestations that aren't really consistent with just primary autoimmune hepatitis, that's when they really should be doing some blood work and sending someone to a rheumatologist. And we'd always rather see the patient than not. One thing rheumatologists don't like to do is what sometimes you call it a curbside, or someone call, can I tell you about this patient? Tell me if you think they might have autoimmune disease. A rheumatologist would always say, no, just send them to my clinic, because I want to do my own history and my own physical. I know everything I want to ask. I don't trust that you asked it everything in the way I wanted it asked to really rule it out. And I want to do my physical because I'm not sure you're good at picking up subtle inflamed joints or something like that. So usually we might say, well, here's the blood work I want you to send, but I want to see the patient in clinic. So this is my last slide, so I'm not getting too specific. So just to kind of review some things that you might have that you might want to say to your hepatologist, gee, maybe I need a rheumatologist. So as I talked about all these before, swelling of the joints, particularly certain joints that are involved would never be just osteoarthritis. So, inflammation of the ankles or the wrists, or certain joints that are really never seen in osteoarthritis. Would that be a kind of a flag that something might be going on? Or it may be that it's only when your hepatologist tapers your prednisone that all of a sudden you start saying, wow, because it may be the prednisone or the drugs they have you on is really suppressing, suppressing any symptoms you may have of the diseases that you should be seeing me for, which is fine. Well, I don't care if they're suppressing it and you don't have that symptoms, fine. But it may be as the medications are withdrawn, that would be when you'd say, gee, maybe I have more than just autoimmune hepatitis. Kind of we talked about with the dry eyes and dry mouth, with oral ulcers, inflammation of your muscles. So if you're really feeling profoundly weak, even when your liver tests, your liver per se might be doing better, that's something to think about. Any unexplained rashes or skin manifestations, unexplained thin skin thickening, a lot of these are just things worth thinking about. So that's really my last slide. They just wanted me to. Sure.
We have time for maybe 1 or 2 questions for Dr. Jacobs.
If a person has a lot of joint pain and stiffness, but they've been tested and they don't have the RA factor and they don't have the lupus factor, is it most likely related then to the AIH?
So first of all, I can diagnose both of those diseases without a patient ever having an antibody, an autoimmune antibody. So that's where that symptom of joint stiffness, where a rheumatologist, I see so many different reasons someone's joints might be aching to them and feeling inflamed to them. Is anything from rheumatoid arthritis to fibromyalgia to whatever. So yes, you could. And that's where, and just to confuse it, you may present to 3 rheumatologists and get 3 different diagnoses, okay? So I'm not even get the art of rheumatology. How do you know you have lupus? A rheumatologist said you have lupus. So it can be a little bit complicated. So if your doctor's not sure, you may want to run by a rheumatologist.
I have a question here.
Great. Yeah.
What about plantar fasciitis? I've had a flare on my plantar fasciitis. I've been in physical therapy for a year, and it's gotten worse while I've been in physical therapy. And it's coinciding with when I got diagnosed with AIH. And I feel like there's a relationship, but nobody else feels like, none of my medical team feels like there's a relationship. And is there a rheumatic relationship to plantar fasciitis?
Well, I would say 2 things. I would say plantar fasciitis is a tough one. And that can take, in a normal person, no other medical illnesses, sometimes a couple of years to get better. And those patients, in my experience, will seek all sorts of alternative care because the routine care cannot make it better. For the most part, plantar fasciitis, so that is the inflammation of the tendon insertion into bone, that can be seen in a certain type of disease we treat, which is not, we call them spondyloarthropathies. They're illnesses where people get inflammation of the insertion of bone, ligaments and muscles into bone, something like that. But that type of illness is not one we think of as being associated with inflammation of the lungs. It's not associated with an ANA. It's not these autoantibodies. So my guess is it's true, and unrelated, as we like to say in medicine. And but that can be a couple. If I see someone with plantar fasciitis, I say to them, let's get you to someone who knows how to treat this because it's not me. And a good podiatrist or a lot of alternative care can be helpful, for that. It's a tough one.
Thank you, Dr. Jacobs. Appreciate it.